of 94%. So, questions. What is the most likely diagnosis? What is the next best step? How would you manage the patient?
Great. Thank you, Adam. So, perpetual Sambila, what's the most likely diagnosis from what you have just said? Perpetual, we can't hear you. All right, looks like Perpetual's line has a problem. Comfort, Koinu, please unmute yourself and let me know what your thoughts are. Augustina Kabir, do you want to unmute yourself?
Please,
Great.
I think she's having a DVT that has resulted in a PE.
Great. You think she has a DVT, which has resulted in a pulmonary embolism?
Yes, sir.
Great. So what is the next best step that you think we should do for this patient by way of management? What do we have to do if you think it's a DVT that has resulted in a PE?
First, we have to put her on anticoagulants.
Okay, you think we should put her on an anticoagulant?
Yes, sir.
All right. You've answered the third question, is that not so? How will you manage the patient? So you think we should do some anticoagulation?
Yes, sir.
Anyone who has a contrary view or has any specifics regards what the next best step is or how you manage the patient, you can just unmute yourself and then, yeah, Nathan, please go ahead. You raised your hand. Nathan Kassan.
Okay, can you hear me?
Yes, please.
Right. I think she should be a drug should be given to lyse the thrombus.
We think we should lyse the thrombus. That is given a thrombolytic agent.
Thrombolytic agent, yes.
All right. Thank you. Any other view? Anyone, you could just unmute yourself and go ahead. All right, I don't see any answer. Yeah,
sir,
great.
Okay, so before she was put on contraceptives, and that's also a risk factor. So if she's still on it, she should be taking off the contraceptives.
Great. So you are looking at removing the provoking factor. So if it's from the contraception, we need to take that off. Well done. Any other? Right, I see that you are unmuted. And then Al-Hassan, you put up your hand. Please go ahead. Just tap on your mic, get unmuted, and then you can go ahead with your submission.
I think judging by the BMI, we should also encourage weight loss in this patient.
Great. You are looking at the lifestyle modifications, so weight loss.
Hello.
Yes, we can hear you.
Yeah. Yes,
All right.
please.
Great. I have a minute more about these three questions. So any other person? Any other submission? You could just unmute yourself and go ahead. All right. I think we have done 10 minutes, so we go. Because we have a finite time to do this, and by 9 o'clock we should be done. I will say that kindly keep yourselves muted so that then we can go through the presentation, and then at the end of it, we can have a discussion. We are hoping to do this within 45 minutes so that then we can discuss further. I'm happy about the input, and thanks everyone who did unmute yourself or made a contribution. That's great. That's the way to go. Usually when you express yourself, whether it is right or wrong, at least you get to know what the issues are and then we can correct them. So make it a habit as a medical student or a medical doctor, usually to speak your mind and speak freely. What's the worst that can happen to you? When you say it and it's wrong, you get corrected so that then the wrong doesn't get impacted on the patient when you start to practice. That's the best to do. All right, so we are looking at venous thromboembolism. Essentially, is made up of two related clinical events, what we call a DVT, that's deep vein thrombosis, and a pulmonary embolism. So we'll look at them one after the other. The first we'll look at is a deep vein thrombosis, or what DVT is. So if you have like the name says, deep and vein and then thrombosis. If you have a thrombus in the deep vein of the body, commonly we refer to that as a DVT. So it's imperative on us to know what the deep veins in the body are. Most commonly, we realize that deep vein thrombosis occurs in the lower extremities. It doesn't mean that you cannot have deep vein thrombosis of the upper extremities. In actual fact, you can have DVTs occurring in the upper limbs, either the left or the right upper limb. And this is also referred to as DVT. But in terms of which one is common, most frequently you have it occurring in the lower extremities, that's in the lower limbs. There are two patterns that are usually classified. We look at how close the clot is to your heart. So if it is something that is more closer to the trunk, we call that a proximal DVT. So if it's involving the legs, you refer to it as a proximal left extremity or lower limb extremity DVT. And then if it is distal meaning that is from the knee downward, so involving the calf vein, essentially, we refer to that as a distal lower extremity DVT. I'm going to throw a quick question. Anyone who would want to answer that could just unmute yourself and then answer. So there's an image here on the right of the screen showing the various, a couple of veins. There's something written there, superficial femoral vein. This arrow shows that, the superficial femoral vein. Is this a deep vein or a superficial vein? Anyone, you can just unmute yourself and let me know.
It's a deep vein.
You say it's a deep vein. Anyone who agrees with me that it is a superficial vein? Anyone? Does anyone think otherwise? So commonly, we want to highlight this because of the name. You see, the name is written as superficial femoral vein. When you are practicing and they do a Doppler ultrasound, which is one of the ways of determining a clot in your leg, and then they make reference that the clot was found in the superficial femoral vein. Although the name is superficial, this is one of the deep veins of the lower limbs. And so it is referred to as a deep vein thrombosis. The reason why we highlight this is that the approach to someone with superficial vein thrombosis is different from those with a deep vein thrombosis, because the risk of a superficial vein thrombosis is not much as compared to a DVT. And that is why we have left it out of this discussion, because the risk is higher with a deep vein thrombosis. And when you mention ventricular thromboembolism, essentially we are looking mainly at the deep veins and then a complication of that resulting in pulmonary embolism. Great. The other one we are going to look at is pulmonary embolism, like we mentioned. So commonly, when you have this clot in your leg breaking off, it can travel, and once a clot breaks off and is in travel, the name changes from a thrombus. A thrombus is in situ, means the clot was formed at that part. But once it breaks off, it's referred to as an embolus. So if a clot is in movement, we say it's embolizes. And once it moves, it can either get trapped off somewhere, causing either a partial or total occlusion of that part. Commonly, the feared complication is when it gets to your lungs, because when it gets in there, you can either have a partial occlusion, which you may be lucky with, or it can be a total occlusion. And a total occlusion, especially what we call a saddle embolus. A saddle embolus, yes, meaning that it blocks both sides of the lung, the bronchi, the left and right bronchus. And when it's that way, you cannot breathe. So we've lost a couple of patients because of that. And death is usually within seconds, because if you don't have oxygen, obviously that you cannot survive. So most of the PEs occur as a complication of lower extremity DVTs, like I've already mentioned to you. And rarely they can come from the upper part. I mentioned that we do have cases where you can have upper extremity DVT. Or it can even come from the pelvis, the vessels of the pelvis, the veins, or even the renal vein. And all these can result in a pulmonary embolism. But common things are common. The commonest is those from the lower extremity DVTs. What are the risk factors for venous thromboembolism? We would want to look at it by describing it as either patient-related risk factor or a certain related risk factor, or an interaction of these. What are the patient-related risk factors? By virtue of somebody having a medical condition can put you at a risk of DVT. This again, we usually describe or try to distinguish it by saying you can have a permanent risk factor or a temporal one, or what we refer to as having a genetic predisposition. Once you are born with that, obviously you can't change it. We'll be looking at a couple of those. And then the certain related risk factors are things that are temporal. Obviously, if I've traveled a long distance and I stop the travel, or I'm no more in hospital, then that temporary risk factor may be removed. Also, we like to know whether the DVT or pulmonary embolism is provoked or unprovoked. The reason why we try to do this is that if it is something that is provoked, you look out for it and remove what provoked it. And then that risk factor becomes a reversible risk factor. And when it is that way, and we've taken off the risk factor, it means we'll have a finite duration of the anticoagulation. However, if we've looked out for what provoked it and we do not find anything, no risk factor, it becomes an unprovoked DVT. And usually when it is that way, we have to look out for the genetic problems and things that may have been there right from birth or by way of a risk factor that you cannot change. The reason is that when we classify you as unprovoked and then there's no risk factor that we've picked up, it means the anticoagulation will have to continue, likely indefinitely in a long time. So this table just looks at the various risk factors. Again, you would like to know whether we have weak risk factors, whether they are moderate or they are strong risk factors. Take note of the strong risk factors. Fractures, especially of prominence in our part of the country where the motorbike is the commonest means of transport. A lot of people come in with fractures and major orthopedic surgeries that we do as a result of these fractures. Major general surgeries as well, spinal cord injury and trauma. with multiple injuries. Usually, we highlight this so that if you know that these are very strong risk factors, once you have such a patient on admission, you have to prevent the person from developing a DVT. Other things, especially as a physician, I would look at, obviously, would be the medical conditions that when I admit someone, I need to prevent you from getting a DVT, congestive cardiac failure, and chronic respiratory diseases. One of the things that has not been highlighted here, but which is of importance in our environment, is liver diseases. Liver diseases are a strong risk factor, a moderate risk factor as well for developing DVT. The pathophysiology is summarized in something that we call the Verkoff's triad. Because of time, I'll just go on so that we can finish up early. So there are three factors that we usually talk about: stasis, hypercoagulability, and vessel wall injury, or what we appropriately call endothelial injury. So it's an interplay of these that result in a thrombosis. And usually when a clot forms, either it stays in the, especially in the deep vein system, or it can embolize and cause trouble. So that's all about really the pathophysiology. It's nothing extraordinary. Once that thrombus forms, then platelets and fibrin will usually get trapped, and then the clot can expand in the blood vessel, or it can even cut off. That's embolize, like we had initially said. The hypercoagulability is also been highlighted here as well. What are the clinical features of venous thromboembolism? Like we said, it's a spectrum, right from having a clot in your leg and how big that clot is, to that clot cutting off and moving, what we refer to as pulmonary embolism. Some people can have a clot without having any symptoms. So you can have the clot in your leg, or even a clot, if not big enough, in your lung without having symptoms. And so we have to have a high index of suspicion, especially in those who have the risk factors that we had previously mentioned. However, the signs and symptoms of both the DVT and the pulmonary embolism, we may need to look at that. So in most cases, if you have a patient that comes in with dyspnea, like the case that we presented earlier, and we asked what was the diagnosis, you realize she came in with dyspnea. Somebody with dyspnea, chest pain, some pre-syncope or even syncope, and hemoptysis. And the key word is that when these are sudden, the symptoms just started suddenly, one of the things to always want to find out or rule out, or at the back of your head, is to suspect a pulmonary embolism. Why do we say this? Because PE is a medical emergency and can kill, and has killed a lot of people. So we would not want that somebody presenting this way with chest pain, dyspnea, pre-syncope or syncope or hemoptysis or any of that, we miss the person. And so once you make the suspicion, like we'll be seeing, you may need to then carry out certain scoring systems. And based on the score of the patient, then we would go ahead to intervene appropriately. Now, there's another variant of it that is extremely important that we have to know. Because if somebody comes in with dyspnea or chest pain or pre-syncope, and then suddenly the vital signs, the blood pressure drops, then we refer to that as a massive pulmonary embolism. Massive does not necessarily mean the size of the clot. Massive is with regards to hemodynamic reserves and how much your BP is, or how much the BP has dropped by. So it's very key that you understand this, because it's one of the things we put in the examination question. What is a massive pulmonary embolism? It does not refer to the size, necessarily to the size of the clot. Rather, it's regards to the hemodynamic stability or instability of the patient. I.e., if somebody comes in with a pulmonary embolism and the blood pressure is lower than 90/60, that's a massive PE, even if the clot itself is very small. Also, anyone who comes in with a clot in the lungs, and the BP suddenly drops by more than 20 units systolic, we also refer to that as a massive PE. So these are things that you should be aware of. And like we said, you can have syncope, and it's usually associated with higher prevalence of hemodynamic instability. And because, like we know from physiology, the blood gets moved to the right side of the heart, and then this deoxygenated blood is pumped to the lungs. If you have a clot in the lung, it means the right side of the heart pumping against an increased resistance. You may have a right ventricular dysfunction. That is the pathophysiology of having right-sided heart failure from a venous thromboembolism. So these are essentially what we just talked about, the dyspnea, and suddenly it may come in sudden as an acute, it may be severe, it may be in the center of your chest, or it may be a small one in the periphery. And like we said, it's a frequent symptom of pulmonary embolism. Some people may even come in with the chest pain typical for angina. They say that when they move, the pain comes on. When they rest, it tries to go. Again, because we said that the right side of the heart may have an right ventricular dysfunction, you may come in with some of these. And so pulmonary embolism is part of the differential diagnosis of acute coronary syndrome, or even some of those who come in with aortic dissection. We talked about the fact that you need to know about the predisposing risk factors for venous thromboembolism, because once you have these, you need to prevent the DVT or the pulmonary embolism from happening. What are the things that you pick up when you examine the patients? We say symptoms are what the patient presents with, like what we talked about, and signs are what you as the doctor will pick up. So what are those signs? What are the things that you pick up as a doctor? Some people will come in with increased breathing rate. The respiratory rate will exceed 20 breaths per minute, or other people say 20 cycles per minute. And that's actually the most common sign of pulmonary embolism. Some people have a heart rate that is very fast, what is referred to as tachycardia. And that is any heart rate more than 100 beats per minute. Sometimes the heart sounds, we have two normal heart sounds 1 and heart sounds 2. The second one, that is the heart sound 2, may become too loud, may become accentuated. And some people may come in with fever. And if it is big enough, you may have some cyanosis. So we have scoring systems that we use to, one, classify pulmonary embolism, and be able to, based on whatever score that the person gets, appropriately institute measures. So if you take anything home today, know that there are scoring systems that we use. And these scoring systems, the important thing is that they actually make use of the risk factors. So if you know the scoring systems, you'll be able to know the risk factors. And we are using the stronger risk factors. There are several of them. There's the Geneva, there's the Well score, there's a modified Well score, and all of that. The one commonly used in practice is the modified Well score. So I would move straight to that one. But just to know, for MCQ's sake, you can have the Geneva clinical scoring system. You can have the revised Geneva clinical scoring system. And usually, based on the factors, you don't need to keep all of these things in your head, because there are tables that usually we paste on the various wards, and it's not fair on an examiner to ask you to list the various parameters in the clinical scoring system. These are supposed to be charts that are readily available for everyone to make reference to. So it's a 3-level scoring system. So anybody who, the original version of the Geneva, if you have between 0 to 3, they refer to that as a low one. The simplified version uses 0 to 1. And then you have the intermediate and the high. Again, when we use the 2-level system, that is referring to it as either the PE likely or PE unlikely. You can use the various scoring systems that are there. But let me zoom straight on to what is commonly used in our country and commonly used worldwide. It's referred to as the Wells score. So there are 2 of them. There's the Wells criteria or Wells score in its original form. And there's what is referred to as the modified Wells score. And also take note that we have Wells score for DVT and Wells score for PE. So these are things that are rule of thumb. And these are the parameters that usually utilize and the various scoring systems that go with it. Again, like I said, we will not want you to cue all of this, like you people will say. We want you to at least know the factors, and then you can always make reference to whatever chart that is on the board. This, in the original Wells score, if you have a score of between -2 because usually when your alternative diagnosis is likely, will give you a score of -2. So the minimum anybody can get is -2. So if you have between -2 and 0, we call that a low risk. And between 1 and 2, moderate risk, and more than 3 is a high risk. The original Wells criteria or Wells score used the 3-tier system. The modified one, which we are going to look at, uses the 2-tier system. And most people now prefer to go with the modified one because it makes things easy for everyone. Again, the risk factors are as shown in the table. And if you have a score of 2 or more, we call that DVT likely. If you have a score of less than 2, then we say DVT unlikely. You will see in the treatment, when we get to the treatment part, that if it is DVT likely, the algorithm, what you proceed to do, is different from when it is DVT unlikely. The same holds true for the pulmonary embolism. I said that, again, for PE, you also have a Wells score for it. And those are the parameters that you use. Again, in terms of the interpretation, in the original form, you have low probability, intermediate, and high probability using the 3-tier original Wells score. Now, the modified one uses the 2-tier system. So that one uses PE likely and PE unlikely. Let me make things simple for you guys. The modified Wells score states that either your DVT or your pulmonary embolism is likely or unlikely. Finished. The original Wells score uses 3-tier system, that is 3 steps, saying that either your DVT or your pulmonary embolism has a low probability, an intermediate probability, or a high probability. And like I said, if you forget about everything, kindly remember the modified Wells score for both a DVT and a pulmonary embolism, because in practice, that's what mostly you would be using. You don't need to cue whatever goes into it. You only need to know that when I calculate and it is more than 4, it is PE likely. It is less than 4, it is PE unlikely. Same holds for the DVT. When it is 2 or more, it is DVT likely. When it is less than 2, it is DVT unlikely. So how do we diagnose venous thromboembolism? Of course, diagnosis of anything or management usually starts from history, examination, findings, and then based on that, you determine your clinical score. I'm getting some feedback from someone. Kindly mute yourself if your microphone is unmuted. So, sorry, let me go back to... Good. So this is what I was talking about regards the diagnosis of pulmonary embolism. We have a couple of people have raised up their hands. Please unmute yourself and let me know if there are issues.
Sir, please, this is Damien. I see that my colleague put some questions on the chat box. I don't know if you respond to them now or we'll respond to them as we go.
Yeah, so at the end, I indicated at the beginning of the presentation, at the end of it, we'll respond to the questions so that then everybody gets the understanding before we do that. Also allows us time to be able to finish up early. I didn't
right,
say at the beginning of the presentation.
So I got lost.
All right. Okay, that's fine.
Right. Thank you.
All right. So what are the differential diagnoses for venous thromboembolism? Several things in terms of a DVT. If you have a swollen leg or a swollen hand, a couple of these may be cellulitis, ruptured Baker's cyst, as well as arthritis, tendinitis, and all of that. For pulmonary embolism, a couple of things may be commonly acute coronary syndrome, myocardial infarction, and congestive cardiac failure, which is both a risk factor for pulmonary embolism and in itself can be part of the differential diagnosis. How do we investigate? The investigations typically depends on the scoring system that we talked about. So if you score and it is less than 2 or more than 2. So take it again from me. If you have a score of less than 2, that is in terms of the DVT, you go ahead to do a D-dimer. So you realize there's a D-dimer test here. If you score and then it is less than 4 for the pulmonary embolism, you go ahead to do a D-dimer. The D-dimer is good for its negative predictive value. I'm sure you guys have done clinical or community health. When we say something has a negative predictive value, is important in ruling out a disease condition. And so when you do the D-dimer and it is normal, it rules out a pulmonary embolism or a DVT, and it will mean that you ended there. But when your D-dimer is high, it doesn't necessarily confirm a pulmonary embolism or a DVT, because several other things can result in your D-dimer being up. All right. So if you have someone with a swollen limb as well, you want to do an ultrasound scan, because the list of differentials we saw, cellulitis is one of the things that can present like a DVT, a ruptured Baker's cyst, as well as several other things. The others include now newer things that they refer to ischemic modified albumin levels. And then sometimes you can do your troponin levels if you do think this is rather a heart issue, that is a myocardial infarction or acute coronary syndrome. You also want to know the brain type or B-type natriuretic peptide that rules in a heart failure if that is the cause of the problem. Also, WBC count, which is elevated, may push you rather to think about cellulitis. Arterial blood gases is key. Unfortunately, we don't routinely do that a lot in our practice, but it's very important, like we saw in the case of the lady that we presented. A chest x-ray, like we'll be seeing, that show some various things that will point out to a pulmonary embolism. But word of caution is that when the patient is not hemodynamically stable, we don't go ahead to do chest x-ray or even the definitive diagnosis of a PE, which is a CTPA. That's a CT pulmonary angiography. So the ECG, we'll be looking at what you see in the ECG. It's a bedside test and routinely available almost everywhere. You can go ahead to do the pulmonary angiography like I've mentioned, and that is actually the diagnostic standard or criterion standard for diagnosing pulmonary embolism. Others would include the very good old ventilation perfusion scan, especially in those who are pregnant, because in pregnancy, we want to reduce the risk of radiations. The D-dimers I did mention that is good for its negative predictive value. Why? Because all these things can elevate your D-dimer. And so if your D-dimer is elevated, it may not necessarily mean that it is from a pulmonary embolism or a DVT. Again, the list is quite long, even including somebody growing older. If you are older, your D-dimers may go up as well. The ECG changes. Commonly, medical students will like to rattle this S1, Q3, T3. People say they don't know what they are saying. They don't know the interpretation. So take a look at it. When we say S1, Q3, T3, means there are 12 leads that we usually use. The lead 1, which is one of the limb leads. If you have deep S waves, I'm sure you guys have looked at ECGs. So in a normal ECG, you have the P wave, which represent atrial depolarization, the QRS complex, which represent ventricular depolarization. And so if you have deep S waves in lead 1, that is referred to as S1. If you have pathological Q waves in lead 3, that is referred to as the Q3. And then if you have inverted T waves in lead 3, that is referred to as the T3. So S1, Q3, T3. Some people may come in with the T wave inversions in other leads as well as the late, what we refer to as the late transition. This is a rare finding. It is not the commonest finding in pulmonary embolism. The commonest finding is sinus tachycardia, just meaning that your heart rate will be more than 100 beats per minute. Some people come in and the ECG is normal. So a normal ECG does not rule out a pulmonary embolism. All right. So, like I said, there are certain chest X-ray findings that you may find out. The Hampton's hum, maybe you guys can read about it. The Westermarck sign. All these are some of the common things that you see in pulmonary embolism. They are not very common signs that we pick up these days because they are better diagnostic criteria rather than waiting for an infarction to occur before you pick that up. So this is the most important slide for me as a doctor. And if you forget about everything that we've talked about, two things that you need to take home are the risk factors and then what to do once you use your clinical scoring system. So if you are sleeping, please wake up now. This is the time to be a doctor. So when you suspect pulmonary embolism in a patient without hemodynamic instability, meaning that you've looked at your risk factors and you think that this patient has pulmonary embolism, what do? The first thing to do is to assess the clinical probability of the pulmonary embolism. How do we do this? You use the Wells score or you use the modified Wells score, which is the commonest used. The other scoring systems like the Geneva and all of that, those who routinely want to make distinctions can add in those ones. In clinical management, most of the times we use the Wells score. Now, if you are using that and you classify the person as having a score of less than 4, that means that PE unlikely. What do? You need to do a D-dimer, like I said. When the D-dimer is negative, hooray, it means that there's no PE, and so you don't need to treat the person. If the D-dimer is positive, I said that the D-dimer is good for its negative predictive value. When it is positive, it doesn't mean anything because several other things can cause the D-dimer to be elevated. And so what do you need to do to say that this is a PE? You need to do a CTPA. CTPA stands for CT pulmonary angiography. And when you do that, this confirms your PE or it rules out your PE. When it confirms, then you treat. When the CTPA says that there's no PE, then there's no need for treatment. Now, when you score the person and the score is more than 4, that means that the person has PE likely. What do? You just need to start treating the person. Once you make the suspicion, you start treating, especially in a setting in which the clinical probability is 4 or more, using the modified Wells score. Once you are treating, then you let the person do a CTPA. If the CTPA comes and confirms it, you continue the treatment. When the CTPA comes and does not confirm it and rules it out, then you can stop your treatment. Why are we emphasizing on this? PE can kill, and PE can disgrace the best of doctors. Like a professor of mine will always say, if nothing will disgrace you as a medical doctor, pulmonary embolism will disgrace you. You do the best for the patient, and the next day you come and he's gone. And at autopsy, at post-mortem, they find that there are claws in there. So it's key that we get to understand these. The second spectrum is those who come and they are not stable. And I told you what we use for diagnosing massive pulmonary embolism. So anybody who is hemodynamically unstable, straight away we say that you have a massive pulmonary embolism. Emphasis, massive pulmonary embolism does not necessarily mean the size of the clot. It depends on your hemodynamic stability. When it is like that, we'll start treatment right away. And usually we do a bedside TTE, that stands for transthoracic echocardiography. And when you document that the right side of the heart has right ventricular dysfunction, then immediately you may need to do the CTPA. Once you are doing all of this, you usually start treatment right away. When you make the suspicion, you start treatment until you rule the pulmonary embolism out. That's very key for us. Now let's look at the treatment. What do we use to treat pulmonary embolism? The key, again, is that we don't say that the treatment is to lyse the clot. It is only when you come in with a massive pulmonary embolism that we are looking at lysing the clot. And usually when you are going to lyse the clot, that is the thrombolytic therapy. You do it in an intensive care unit. That is key. Now, the other things that we usually give That is either the low molecular weight heparins, the warfarin, that's the vitamin K antagonist, or the newer agents that have come, what we call the NOAC, new oral anticoagulants. Usually these do not lyse the clot. That's another common question in the MCQs. We don't lyse the clot with given warfarin or heparin or the new agents, the new oral anticoagulants. What they do is that they make the clot stable so that it does not form any further and doesn't break off. That is key. So please take note of that. There are scoring systems that usually, again, we use to assess your risk of bleeding. One of them is referred to as the has bled. It does not mean that we won't treat you if your has bled score is high. It only tells us that you have a high risk of bleeding, and so we'll monitor you appropriately. Somebody did mention about thrombolizing the patient that had presented. The key thing is if you have an acute massive pulmonary embolism causing hemodynamic instability, typically we want to thrombolize, we want to cut off that clot, we want to lyse that clot because you can die within seconds. There are also other surgical interventions that can be done. That is like removing the clot. That's referred to as the thrombectomy. Or sometimes we do venous interruption to divert the blood flow from that clot. Now, there are indications for thrombolysis, and there are also contraindications. The indications are what I had already talked about. There are contraindications, reasons why you cannot thrombolize somebody, and they are what have been listed there. These are the more important ones because they are absolute. When they are there, you don't need to thrombolize the person. These are relative, meaning that you could still thrombolize, but you need to be careful and you weigh the risk versus the benefit. There are emerging therapies that are coming up. And in your practice, I'm sure these are the things that are new to everyone. And once you start practice, they will become old. Already they are in clinical practice. The commonest one we have in our country is the direct factor 10 inhibitor, referred to as rivaroxaban. There are other inhibitors, like the indirect ones, fandaparinux, and then the direct thrombin inhibitors like agatroban. Also, we have apixaban, which is common in the US. The other good old things are the unfractionated heparins, which block the intrinsic pathway. I'm sure you guys have looked at in physiology and in pathology, the clotting cascade, and then the low molecular weight heparins as well. Same ones that we have talked about. Immediately you make the diagnosis or the suspicion, you need to look at treating the person. And then you need to look at the long-term treatment of it and removing the provoking factors. And where you don't find any, you may need to treat indefinitely. How do we prevent ventricular thromboembolism? This is very key. In our wards, like I tell my doctors, anybody who is on admission for any medical disorder or medical condition, except contraindicated, the person has to be on thromboprophylaxis. My surgical colleagues, especially those of them doing obstetrics and gynecology, and then those who are into trauma, it's also key that thromboprophylaxis be given to all these patients. Because if you look at the risk factors, those were of higher risk factors or higher risk of causing thromboembolism. So it's key. Now, there are some people who may be bleeding. Like I have a patient with hemorrhagic stroke on my ward. In the first 24 hours, it will be difficult to make the blood lighter. So ideally in those settings, like we have in the stroke unit in Kolebu, you have intermittent pneumatic compressions. These help to prevent ventricular thromboembolism as well. So I can't overemphasize that all acutely ill medical patients on admission, whether you are with heart failure, respiratory diseases, you have neurological diseases, or even inflammatory bowel diseases, although they are bleeding in the intestine, the risk of clotting is very high. So we'll put them on thromboprophylaxis and should be considered in all surgical patients as well, with either the moderate or high risk of venous thromboembolism. And everybody, not some, everyone, undergoing pelvic and orthopedic surgeries, because the mortalities are usually from pulmonary embolism. I think we have succeeded in doing this in about 40 minutes. We have 10 minutes to 9 o'clock. And so we'll look at the questions and any other discussions that may come up. All right, so the first one that I see is from Alasan. Why is DVT? Alasan, could you unmute yourself and say hi to us? Is Alasan on?
Hi.
Good. So your question is, why is DVT common with lower limbs as opposed to the upper limbs or any other part of the body? Is there anybody who has an answer to this question based on what we have just...
Yes, please. Hi.
Yeah, go ahead. Please go ahead with your answer.
Yes,
You can
please.
just unmute yourself, so that I know that I've done a good job, because all these questions should be answered by us. Anyone? Why DVTs are common in the lower limbs than the upper limbs? All right, so if I don't get any response, I will mention some names as appear on my screen. The first one is Abbas Hamid. Please, what do you think about his question? Abbas, go ahead. Just unmute yourself.
Hello.
Yes, please go ahead.
So I think DVTs are common in the lower limbs because of the muscles down there, the soleus pump. They tend to push a lot of blood up, and sometimes there may be stasis since they are pushing against gravity.
Great, Abbas. I see Mohammed's hand up. Mohammed, do you have something to add? Please unmute yourself. Mohammed Abdul Kadir. Mohammed, you are unmuted. Please go ahead. All right, so DVTs are common with the lower extremities. One, because, yes, Mohammed, your line is breaking. All right, so let me just respond to that. They are common in the lower extremities. One, because usually once you get immobilized, or you get, I think I have to mute Mohammed, was okay. All right. So once you get immobilized, once you get into hospital, commonly you realize that when you are lying or sitting in bed, your hands do move rather than your legs. And so commonly that's one thing. Another thing is by the effect of gravity. Obviously, blood collects in the dependent parts. And like we said, if you listen to the pathophysiology, it's an interplay of three things. So anytime you have venous stasis, like Hamid rightly said, if you have venous stasis, that is blood not moving, the tendency to clot is high. And so this is more common with the lower limbs than the upper limbs. All right, let's look at the next question. Abdullah Zenya, can you say hi to us? You wrote a question in there. Abdullah Zenya.
Hi.
Good. So your question is, do we still call it DVT if it involves the deep femoral vein? If yes, how do we differentiate the two? How do we differentiate which from which? Zenya, please clarify yourself. Abdullah.
How do we, yes, please. How do we differentiate the DVT of deep vein thrombosis from DVT of the superficial vein, femoral vein thrombosis?
Let me correct you. So when we say DVT, that means deep vein thrombosis. So we don't have DVT of deep vein thrombosis and DVT of superficial vein thrombosis. So what we have is DVT, that is deep vein thrombosis. And then we have superficial vein thrombosis, that is called SVT. So in terms of differentiating SVT from DVT, you do it with an ultrasound, a Doppler ultrasound. So if you find a clot in the deep veins, like I showed you in the figure, that means it is a DVT, that is a clot in the deep veins. If you find the clot in the superficial veins, then that means it is a superficial venous thromboembolism. So that's the way to distinguish, doing a Doppler. And typically, if it involves the deep femoral vein, like you rightly mentioned, this is whether the deep femoral vein or superficial femoral vein. Again, I want to emphasize that the superficial femoral vein, although the word says superficial femoral, it is one of the deep veins of the leg. It is a superficial femoral vein, but all the femoral veins are deep within the legs. And so they are deep veins of the leg. And so when it involves whether the deep or the superficial, we'll call it a DVT. All right. And then you also ask, when do you say a surgery is a major surgery, such that it predisposes to DVT? So typically, the anesthesia people will tell you that a major surgery is one that you are going to make the person sleep. Is that not so? And once you sleep, obviously, you'll be in bed for a couple of hours and immobilization would come in. Some people use the time category as well. I'm not a surgeon, I'm a physician, but obviously once you have either a surgery in the pelvis or you have an orthopedic surgery or any of that, we consider it a major surgery because the risk is higher. So if you go back and look at the risk factors I gave you, we wrote specific surgeries that have higher risk factors, and it is important to take key of these. I see Alasan likes a lot of questions. To elicit tenderness, one has to palpate. Won't this increase the risk of breakage of the clot and potentiate pulmonary embolism? Fantastic. So I'm happy about this, your question. I want to ask you people in your reading, anybody can unmute yourself and answer this. There's something called the Homan sign. Who has ever seen it before? If you have, just unmute yourself and say yes. Homan sign.
Sir.
Fantastic. What is the Homan sign?
Homan sign is when the patient feels pain when he or she dorsiflex the foot.
Great. In the past, this was one of the things that clinicians use to assess for DVT, but it is obsolete. It is in the museum. It's no more done. So we don't elicit, we will not want to palpate or press on your calf vein. Like your question rightly said, this increases your risk of DVT, your DVT embolism. And so we don't do that again. There are better measures. There are better ways. Once you assess your score, you follow what the score says. So if it is high, start the thromboembolism treatment, and then you can do a Doppler. If it is a PE, you start the treatment and do a CTPA. If it is low, you do your D-dimers, which if negative will rule it out. So there's no rule for going ahead to move and manipulate somebody's leg. What you essentially do is that you cause a PE and you may in effect kill the patient, which is wrong, which is unethical, which is unacceptable. What accentuates the second heart sound as stipulated in the clinical presentation? So if you listen to me, I said there's some right ventricular dysfunction. And so this leads to accentuation of the second heart sound. Then can drugs such as aspirin, clopidogrel, and clexane be used? Are they anticoagulants or thrombolysis? So you've mixed a couple of things. Aspirin and clopidogrel are antiplatelets. They are not anticoagulants. Clexane, we don't like you using brand names. So clexane is referred to as enoxaparin. It's one of the low molecular weight heparins that you saw me write in there. There are other ones like dalteparin and all of that. Then are they anticoagulants or thrombolytics? They are in no way thrombolytics. They are anticoagulants. So the enoxaparin, the brand name clexane, is an anticoagulant. Aspirin and clopidogrel are not anticoagulants. They are antiplatelets. And in terms of thrombolysis, we usually use either alteplase or streptokinase, where any that is available. That is the last question I have in there. We have 2 minutes to 9. If you have any question, if you have any contribution, kindly put up your hand. All right, I don't see any hand up. Damien, do you guys have a lecture at 9 o'clock? Or any of you can answer that. You can just unmute yourself. Do you have a lecture at 9?
Sir. No, sir, we don't.
All right. So we can allow some time for any discussions that may come up.
Yes, sir. But
right.
we do have what sessions.
So should we close now?
So we can just leave some few minutes for the discussion.
So 10 minutes is fine. Is that also?
Yes, please. Yes.
All
please.
right. So Mohammed, please go ahead with your question or your contribution.
Sir, please, I wanted to ask, in our setting where the CT pulmonary angiography will be expensive, and you've already started your treatment for PE likely when it is greater than 4, is it that when the patient cannot afford the CTPA, you observe the treatment regime maybe by doing an iron out, then stop the treatment when it is in the therapeutic level, or I don't know, you have to get your CTPA to stop before you can stop the treatment?
Good question. So there's what is called standard medicine, evidence-based medicine, and there's what is called APROTEC, appropriate technology, where things are not available. It is of no place that we should not be able to do a CTPA because that's the gold standard. But if that is not available, there are other things that I did mention, like a VQ perfusion scan. Again, that is not too readily available as well. But what is readily available in our environment include an ECG. If you have ECG evidence of it, you can go ahead to treat until you get a CTPA. Again, bedside ultrasound. Ultrasounds are available everywhere. Everybody buys some and put in a small room and does scans. So in the emergency settings, there are ultrasounds that you can just put the ultrasound probe on the person's heart. Once there's right ventricular dysfunction, you can go ahead and continue your treatment. Like I said, when you make the suspicion, until you rule it out, you cannot stop. If the PE was likely and the score is more than 4, take it from me, when you do the D-dimer, it will be elevated. So that's why we don't want to waste the person's money in doing the D-dimer. So if it will take, usually the treatment, the shortest duration of treatment for PE is about 3 months. So you can continue your treatment until the person does the definitive test, like the CTPA or the VQ mismatch or an echocardiography or any of that can rule it out. So the risk of dying is high and we can't quantify human life. If you say it is expensive, it's about weighing dying versus paying some money to do the CTPA. So sometimes as practitioners, as doctors, you need to explain some of these things to the patients. In terms of availability, that's where rather my issue is. If you are in the village, as the doctor in the village, where there's no CTPA, there's no CT scan or any of that. Once we make the suspicion, continue the treatment, refer appropriately to where they can do this and exclude it. Why? Because when you miss a PE, you treat for a short while and stop it, it's as good as not treating at all, and then the person may die. And of course, that will not be good to human life. We can't bring back human life. All right. Any other question? Okay. So in the absence of any question, I would ask you some few questions based on the case scenario that we did. I'll take you back to that one, and then we'll answer some few questions so that I get to understand that you guys did understand the lecture that I gave to you. These were our objectives. I think we have about 7 minutes, so we'll use that to go through this. So let's see if the objectives have been achieved. We said that at the end of the session, we should be able to define what venous thromboembolism is, or venous thromboembolism. Abdallah Nuruddin, please, what is venous thromboembolism? Please unmute yourself. Abdallah Nuruddin. I don't see Abdallah unmute himself. Abdul Momin, Isa. Abdul Momin Isaku. You guys, don't make me feel bad that I haven't taught you anything. Yes, Abdul Momin. What is venous thromboembolism?
So it's the presence of a thrombus in the deep veins of the body.
Fantastic. So it's just the presence of a clot in the venous system. Is that also? So thrombus formation in the venous system, like my first slide said, that's the definition. So whether in the deep veins or in the pulmonary vein, this is venous thromboembolism. Abdul Momin, please mute yourself because the guinea fowls are noisy in the background. Now, the second one was to be able to identify the risk factors associated with venous thromboembolism. I guess we have been able to do that. We looked at the various risk factors, those that are high risk or weak, moderate, strong risk, moderate risk, and weak risk factors. And so please take key notice of the various things that we say are strong risk factors, as well as the moderate risk factors. So that then if people have a combination of these, you won't wait for the person to get a DVT. The other one was to know about the pathophysiology of venous thromboembolism. I think that is summarized in the Verkoff's triad. And then to describe the signs and symptoms associated with venous thromboembolism, which we were able to do. Some people may present without signs and symptoms. Others may come in with chest pain, breathlessness, cough, and sometimes the cough is even productive of blood in the sputum. And commonly this happens suddenly. And we said that the symptoms are what they will present with, and the signs are what you as the doctor will pick up. And how to investigate and manage venous thromboembolism, and how to prevent. So I'm going to go back straight to that slide. The most important slide for me for today is this one. Two of them, this, two of them. So somebody who is hemodynamically stable and somebody who is unstable, what to do. And that is all about pulmonary embolism once you make the suspicion of it. In terms of the prevention, as doctors, every patient on admission, except he has a contraindication, which we looked at, will need to be put on thromboprophylaxis. I guess we have been successful at doing everything about venous thromboembolism or getting your understanding about it. Now I'm going to go over this case. We have about 3 minutes so that then you understand the various parts that were picked up. This is someone who is 36-year-old. Age is a risk factor. This person's age is not a risk factor for him. The age we are looking at usually is 40 and above. 70 even puts it at a higher risk. And we said that the initial presentation was pain and tenderness in the right lower limb. So that's one of the signs and symptoms. He came in with syncope. You realize that symptom of pulmonary embolism, syncope, breathlessness, chest pain. And they said this was preceded by 9 hours of immobilization due to sitting in a car. So this is one of the modifiable risk factors, prolonged distance travel. The number of hours we use for that is 4 hours. This 4 hours or more, this person had 9 hours. And so that is one of the risk factors that we'll pick up from this history. This 36-year-old woman was diagnosed of PCOS, polycystic ovarian syndrome. It is one of the risk factors as well. Again, the treatment of it is another risk factor. So she was currently being treated on a monophasic combined oral contraceptive pill. Like if you see in the risk factor, the contraceptive pill, especially the combined one, is a risk factor. And she has been on this for 4 years. So obviously you are picking up the various risk factors that we are looking at. And so you should now just start calculating your Wells score or your modified Wells score. The patient had no history of smoking because smoking is another risk factor as well. and no alcohol abuse, and no family history of cardiovascular diseases. So we have looked at the signs, the symptoms, sorry. Now we are looking at the signs. When this person was examined, the BP was 120/80. You realize that this BP is normal. She is not hypotensive, and so the person is not hemodynamically unstable. Because he's hemodynamically stable, what we need to do is to get your well score, and based on the well score, if it is less than 4, we'll go ahead and do a D-dimer. If it is more than 4, we would do a CTPA. But in the midst of doing all this, you start treatment because you suspected it. In pulmonary embolism, suspicion is equal to treatment. One of the signs we said, and which is actually the commonest sign of pulmonary embolism, is tachycardia. This person came in with a pulse rate of 105. We said tachycardia is any heart rate more than 100. He also came in with increased respiration, tachypnea. We said that's the commonest sign of pulmonary embolism. And they had tenderness in the right lower limb, obviously saying that the clot formed in the right lower limb and went up. This person is overweight. Overweight is one of the things, the risk factors, because of sedentary lifestyle. Otherwise, there were no deviations from the norm when he was examined. Immediately an ECG was done, and the commonest presentation of PE was picked up. That is sinus tachycardia. She had the rare presentation of PE, S1, Q3, T3, and I explained to you guys what that means. And even had an anterior and inferior wall ischemic myocardium. That means that they did an echocardiography. That is a video of the heart. They went ahead to do arterial blood gases, and they realized that her PO2 was low. That is the partial pressure of oxygen. And then the carbon dioxide was 30, which was also low. So this person has what we call a type 1 respiratory failure. And the saturation was borderline low as well. So all this tells you that, one, this person has evidence of pulmonary embolism. And this pulmonary embolism is hemodynamically stable. When you do the well score, you realize that her well score will be about 4. And so what we need to do, because we suspected it, we'll start treatment right away. And the treatment, typically, we usually start with the heparins. And then the long-term treatment would be one, we have to withdraw what is causing it. And then we'll go ahead to plan whether to continue on the new agents if you can afford, like the rivaroxaban, apixaban, or idubatram. And then we can also look at giving the good old warfarin. But anytime you are giving warfarin, you need to monitor what we call the INR, because warfarin inhibits the vitamin K-dependent clotting factors, and that is the extrinsic pathway of anticoagulation. So we've succeeded in using this case to discuss, one, about the clinical presentation, that is the symptoms and the signs. We've also looked at the various investigations that you do and the Wells score and what you do when the score is less than 4 and when it is more than 4. We also looked at whether the person was hemodynamically stable or not and how you are going to treat this person. So that would bring the curtain down on our presentation for today. Thank you guys for making time for this presentation. I hope that you did enjoy it and then you carry the message of ventricular thromboembolism forward. God bless you all. I see that Godwin has his hand up. Please go ahead, Godwin. You can mute yourself.
All right. Boss, please, I want to find out, you said when you use the anticoagulant, you are only trying to stabilize the clot, but you don't try to break it. So in the long effect, can you introduce the antithrombolytics if you intend to break the clot? Or what's the fate of the clot in the long term?
Yes, so like I told you, we only break the clot when the person is hemodynamically unstable. That is lysing the clot. There are risk factors for lysing the clot. So unless it's really indicated, we don't want to use the lysis of the clot. It is not the clot that has already been formed that is the problem. The problem is breaking off and a lot of it going. And so when it is that way, we would want to prevent a lot from forming and a lot more from breaking off. And that is why we give the anticoagulants. And they stabilize the clot, they do not break it. And so unless you have hemodynamic instability, we would not want to lyse your clot. Again, like I said, the clot lysis of it is done in an ICU. Sometimes when you try to lysis, that is what will kill your patient. And so it's key that we take note of when we use what. Again, most places don't even have intensive care units. And so if you don't have an intensive care unit, it means that you cannot do your thrombolysis because you need monitoring. And so you don't do it at the bedside. These are the things that we have to be careful about. So I've gone back to the slide talking about the P. So it's patients with acute massive pulmonary embolism causing hemodynamic instability that may be treated initially with thrombolytic agent. That is your take-home message. Don't mix the two. This is the only reason in P that we would lyse your clot. And so if you don't have this indication, we don't go ahead to lyse the clot. And that's the indication again there. And it is the only one, hemodynamic instability, if you have the P. If it is stable, we don't go ahead to lyse because you may kill the person. You may get hemorrhagic stroke. And these are the contraindications. All right. I still see your hand up. Please go ahead, Godwin.
So it's done. Thank you very much.
So lower your hand then. All right. Any other? Okay, so thank you guys for participating. Yeah, Alasan.
Sir, please, I wanted to find out how lysing the clot can actually lead to stroke, hemorrhagic stroke.
Yes, so lysis of the clot, like you said, it is a chemical you are given to break down the clot. This chemical cannot distinguish between what is a clot and what is a vessel and causing endothelial injury. And it is systemic. You give it injection. So it goes through all the vessels. The vessels in your brain are very tiny, like a balloon tick. And so if you have endothelial injury, which we did say that is one of the predisposing risk factors for venous thromboembolism in itself. The risk factors for hemorrhagic stroke usually include when you have clotting abnormalities. And so you can iatrogenically cause clotting abnormalities by giving the chemical tissue plasminogen activator, what is called the alteplase. So these are the reasons. So we are key in deciding who we have to who we have to give thrombolysis for. If you look with me, Alasan, on what is currently listed there as contraindication, you see that we have one of them captured there as active or recent internal bleeding and history of hemorrhagic stroke. So anybody who has ever had a hemorrhagic stroke before, we can't even lyse at all because you cause another one, in addition to other bleeding diastasis. So these are the reasons. I see you guys like thrombolysis a lot. It's not something that is commonly done. It's only done in the intensive care unit. So don't be fascinated by it. And it doesn't mean that if your clot is not lysed, you will die. The right thing is to get the clot stabilized. Even when you lyse it, at the end of it, we will still need to continue on getting the clot stabilized because it's not everything that you are lysing. Any other? Okay, so thank you guys for joining this presentation. I hope it's been beneficial. And please carry the message out there that venous thromboembolism is real. And if you've forgotten about anything at all, I beg you, do not forget about the risk factors. And these are captured well in the modified World Score. And as a doctor, if you ever admit a patient to the medical ward, unless the person has a contraindication, like we are seeing on my slide, or has a bleeding diastasis, please make sure that this person has some prophylactic anticoagulation. As a surgical doctor, especially if you work in the obstetrics and gynecology unit, where a lot of pelvic manipulations and pelvic surgeries are done, or if you work in the orthopedic ward, we'll say that as much as possible, please put people on anticoagulation prophylactically against a DVT and against a PE. Those who cannot be on it, there are other agents we use, like the intermittent pneumatic compressions. We lose a lot of patients from PE and venous thromboembolism. And like my good old professor always say, if nothing will disgrace you as a medical doctor, pulmonary embolism will disgrace you. So please take note and be a good advocate for venous thromboembolism. Thank you very much. So class rep, is there any other issue? Otherwise, then we can close the session.
No, sir. Sir, thank you very much for making time for us.
All right, all the best.
Sir, I'm sure you send us the slide.
Yeah, I'll do that.
Right, sir. Sir, thank you very much. Have a good day. Bye-bye.